Okay. Yes, fair enough. Yeah.
all are dealing with day in, day out. So we all have had such patients like this 45-year-old gentleman who came to my OPD and he had history of recurrence back. Started on oral and topical antivirals because it was stromal necrotizing keratitis and started to respond, but there came an area of thinning for which AMG and tarsorrhaphy was performed. Responded after that, and patient healed, the cornea healed with scarring with prophylactic antivirals. Started, as is very common in our country, after 6 months, he stopped the antivirals and within a month, within 10 days came back to us with recurrence. Again started, and then prophylactic antivirals continued with much more of understanding and counseling of the patient that this is the most important thing to do. Before we just go forward, we just have to understand why all this paraphernalia of HSV occurs, because this is a very strange virus. It's a DNA virus with linear DNA and icosahedral capsid there. And what I would just say is the number 5, which is the non-coding RNAs, which are called as LATs. They are latency associated transcripts. And they play a lot of role in what we all deal with, and that is the recurrence, or why is it staying latent and why it comes back. So if you just look at the replication, it can continue replicating in the cells, or it may become dormant because of some of our body evasion strategies. And then it goes into the ganglion and stays there. So we know there is already establishment of latency and reactivation, and HSV can exist for lifetime. And we know 90% of the people, when they turn 50, they may have HSV somewhere in the body. What is the puzzle of HSV? Why are we also intrigued by this? And more so in India, it's not just about the epithelial keratitis which leads to minimal scarring. It's one is varied clinical presentation, then we have limited treatment options. When I did my residency, I had acyclovir, and after 20 years, I'm again at acyclovir or ganciclovir as the main drug. Nothing new has come on that. And there are unpredictable recurrences. So if you look at the varied clinical presentation, we know that it comes up with epithelial or stromal, and with this newer classification which has come up, we are classifying it by disease location and not by the historical terms of necrotizing or disciform. We're now using it more on the disease location. If we just understand the etiopathogenesis, we know that the HSV goes on the epithelial cells, may become latent, and when a stimulatory factor comes, and it may cause a recurrence. So how does that happen in an epithelium? It is basically the lysis of the cell of the epithelium which occurs when HSV evades in, which is at the envelope, and then it may just lead to a raised dendritic lesion. And if the interferons and HSV specific IgG and IgA are good enough in the tears, it will, this is like the host evasion strategy, it will not go into a dendrite only and will resolve. That's why we know that epithelial may be a self-resolving. Even if you don't treat, they will resolve. But we have now good treatment as well. In stromal, we can have an early and a late phase. Neutrophils are more for the early phase where they're trying to counteract the lysis happening. In the late phase also the neutrophils come up, but at that point it's more the angiogenesis which is happening. So a triad, I always say, it's an immunopathological disease, and evasion is mainly of the stromal fibroblasts here, but our innate and adaptive immunity will play a role in how virulent that episode of infection be. These are some of the key cytokines which are produced during infection, and some of them are more for viral replication, and they are the good ones for the eye, for the body. I'm just going very easy on that. It's interferon alpha and beta, and some will lead to inflammation and neovascularization like IL-6, IL-17, TNF. But a balance is needed, and there has to be some strategies to block cytokines. They have proven effective in decreasing the pathogenesis in mice as of now. The next comes unpredictable recurrence. This was a case which was thought of as a PBK post cataract surgery 2 months later, and the DMEC was done here, and after that on the surface developed a geographic ulcer. So right from the beginning it was actually not a PBK but a viral etiology throughout. These things do happen in our practice. So why does that recurrence come up, and what makes this HSV latent? And that's basically a balance which has to be striked between them. So there is definitely a need to understand the disease clinically, more of pathogenesis going into that, and at a molecular level. So we started some of our projects at our hospital, and I would be very humble in saying that till 2022 we were just doing clinical. Whatever we knew, we were just treating it on that. From September, we started working on a molecular level, and I would thank Dr. Anil Tiwari, who was the chief scientist who worked with us and gave me the insight of how we can go into the molecular basis of the study, and currently we are at the biomarker identification for HSV keratitis. And that's what came to our mind was that we have to have a biological molecule that is a sign of a healthy or a diseased condition. Because what as clinicians I always used to argue was that, can you just tell me the time when the eye squeeze in so that I can go and perform a keratoplasty if needed? Or can you tell me, is this 400 milligram BD of acyclovir a good dose for prophylaxis in this particular patient? Is it actually making the cornea quiescence? So that these are the things which as a clinician used to come to my mind, and I wanted to go in for some sort of translational research and not just a molecular research which may not go to the improved health of the patient in the sense. So we went in for our patient research. So how do we understand? We started doing it in two phases. First, understanding the tissue state by taking the corneal scrapes and impression cytology, first doing the viral detection by qPCR and also biomarker detection by RNA isolation. So we were doing both RNA and DNA isolation from the scrapes, and we also wanted to understand the tear dynamics, because in future, if you're going to make it very practical for all ophthalmologists to use, it should somewhere be evident in the tears, because not every clinician would like to take scrapes at every point. So there we started doing protein isolation and started getting biomarkers there. And same biomarkers which we were doing in scrapes, we tried doing them in tears and trying to correlate them. The first we did was correlation, where we wanted to know how many biomarkers to study, and then a clinical validation. So this was more like the starting discovery phase, as I say. In 3 patients we did, and we found more than 6,000 dysregulated genes. We can't go in for that. And then we got this heat map wherein we could isolate some biomarkers which would be the ones which we wanted to study later, which had some sort of correlation, because dysregulated would be somewhere up, somewhere down, and is not significant. So then we came to some small category of those significant biomarkers, out of which the IL-17 and IL-6 became very, very good markers for the viral. So we enrolled 25 patients wherein we were with the clinical phenotype of HSV keratitis, where we expected an active HSV virus there. That means they were either epithelial keratitis or stromal keratitis with epithelial damage, or stromal necrotizing in our terms. So these were the several biomarkers, and they all had specific effect, proven effect on the corneal epithelium there. And then we found that this was one of the earlier stages, that when we compared it from the controls, and controls we took epithelium from the PRK cases which we were doing for refractive. So when we started doing these panel of investigations, we found that the VEGF and the IL-6 and SLUP, they were increasing, and similar levels of ELISA from the tears were also found to be increasing there. So that came to our mind that, okay, if somewhere we can correlate them, then tears may also serve as good samples. And then when we went on serial molecular analysis of the same patient at the active and the result, we came up to certain markers. So if you just look at the last one, the IL-6 in control is minuscule, at an active form is high, and then when it becomes resolved, it has come back to the initial level. And similarly in the proteins which we were trying to do from the tears. So we did this correlation plot, and again it came out to be a very important factor when we came to the activity of the viral keratitis. And this was one of the earlier papers which came up from us, where we did it for the PED from viral keratitis. Now came, how do we come to this? So this was one of the patients who presented to us, and at the time of presentation, as you can see, the levels of the biomarker were very high. And then the patient started to resolve after the treatment of topical and oral antivirals with adjuvant treatment, and the levels of the biomarker came down. But again, the patient stopped antivirals and came back with recurrence. And again, if you see at the point of recurrence, the levels increased. And then when we treated the patient with the antivirals, the levels came down. So somewhere this made us believe this patient, we call him as the most important patient, and all this, our lab knows the patient, and this is the patient who taught us how to go ahead with this the study. And this is another patient where again you see at the control it is level is very low, and that at activity it is high, and as the patient resolved, even 6 months later, the levels did not come up. This was another patient who taught us post-keratoplasty having recurrence. And then again, when the patient presented with recurrence, the levels were high. And as the patient resolved with antivirals, the levels came down. And this is how we got into these 25 patients. And this was, again, apart from the biomarker, we also went in for the soluble receptor of the same biomarker, which again showed similar disease. So these are the important cytokines which we define. IL-6, as we know, is we know it's a pro-inflammatory role, and it's we cannot specifically put it for viral. It can also be because of poor tear film. Also, when you can have IL-6. So we have to come to a more specific. And now a lot of our research is now concentrated on IL-17, which we are trying to make it more specific for HSV. And if we have it, we may have a battery of 4 or 5 markers which anybody can do it if the patient comes to us. I will just take 1 minute more if that's okay. So if you look at the limited treatment options, we have ganciclovir, acyclovir, and trifluridine, which have been there, as I was saying, from years back. But can we have something else? And when we come to the treatment modalities, what's new, and this was one of a very small minuscule of, we did it in a large cohort in our hospital, a retrospective analysis of surgical intervention, and out of the 1434 patients which were taken at a duration of 3 years complete, 377 underwent surgical intervention. And most of the patients who underwent surgical interventions were HSV stromal necrotizing. And the type of surgical interventions which happened were tarsorrhaphy, TABCL, tenon patch graft, amniotics, keratoplasty, Gunderson's Cape, or even evisceration. And you see that more than 130 patients had to undergo a keratoplasty, which may be in the form of a TPK. We sometimes get those cases you have to operate even if you know it's a fair prognosis, and an OPK as well. So where are we today on that? If we say are antivirals the ultimate treatment when it comes to viral keratitis, or can we have some sort of parallel treatment along with this, which can reduce the scarring which happens on that? So can exosomes be the potential therapeutic, because there's a lot of talk about exosomes everywhere. And so we did another experiment wherein we took the primary culture of the HSV patient and created a cell line. And then we did an RNA extract, and on that we started putting the exosomes. And if you look at it from the scientist part of view, you can see that this is just the HSV1 stromal keratitis, and the moment you have these the exosomes there, you can see that the fibroblasts before and after the treatment, they have reduced. So somewhere that is also leading to an anti-inflammatory effect. So this was done in our lab, where the cell line of HSV was created, and it was done experimentally. And this was done by a graft which was done for viral keratitis, and that tissue was used as the primary source of the cell. At that time, we did not have anything coming from outside. So why do some individuals develop and some do not? All of us do not, and they just may shed virus asymptomatically. And as a clinician, I'm not bothered. If you're asymptomatic, I'm happy. I do not want to treat you. So then came the role of epigenetics, which is basically heritable changes in gene expression and cellular phenotype, and they do not cause changes in the DNA sequence, but some sort of non-coding DNA sequences, and it may be due to environmental factors, it may change on that. So if we look at epigenetic events in the cornea, they can be in corneal homeostasis, corneal differentiation, and wound healing. So we went ahead and did an experimental study on KLF4 methylation, and we found that hypermethylation was seen in the patients of HSV keratitis here also. So this can also be, now we know that epigenetics is coming up in a big way as treatment for cancer therapy, but again, it's still an experimental way here where we are doing it right now, but this has shown it very clearly that this is hypermethylated in HSV1 keratitis as well. So again, to summarize, I would say there are challenges in HSV keratitis, and if we look at each challenges, somewhere we have to go on and working, and we are trying to work on that. And for unpredicted recurrences, we are going in for HSV biomarker monitoring and epigenetics expression and exosome therapy as one of the adjuvant therapy to take care of the limited treatment options. I cannot thank enough the lab and the scientists who have been working on it and making me understand HSV much better as I used to before 2022. And these are some of the publications we have. And this is our team of scientists and my Cornea fellows who work with me as a team. And that's why we've been able to come up with this. And also acknowledge Aisha Group Foundation, SERB DST for the startup research grant, and Patients for Cooperation, and giving consents for the samples. Thank you so much for your time.
Thank you.
As Dr. Praveen sets up his slides, I have one question. When you are evaluating a case with multiple recurrences, how often do you find out that it's CMV instead of HSV?
So that is always a panel of viral markers, viral diagnosis which you do. That's a CMV and an HSV 1, 2, and that panel is done. Currently, we are not segregating that, thinking that obviously we all know that the treatment may not change. It may just be from acyclovir, maybe a ganciclovir, which we would like to give. But that's something which we are working on. That's why we've started another arm now where, I mean, recently, yesterday only when we were talking about it, we've now having the panel where it's going to do it on a DNA level, which type of virus it is. But we all know that HSV still remains a clinical diagnosis, and any viral, even with CMV, we may not get a positive CMV even on a PCR in most of the cases. That's what is happening.
Thank you.
But in multiple recurrence, CMV is the first thing which comes to the mind when it's not responding to the normal 400 milligram BD and it comes back.
Yes, yes. And so then ACHARYA doesn't really work,
it doesn't
and
work.
it leads to recurrences and failures. Yeah.
Thank you.
Thank you.